One of the high yield topic on the NCLEX and the fundamentals of nursing is what? Fluid, electrolyte, and IV therapy. Welcome to Pharmacology Test 16. This is talking about very high yield information. If you're struggling with this fluid, electrolyte, IV therapy, I have 15 questions trying to give you all the key facts you need to know, in addition to what? Those calculations. You want to stick around. If you've never followed this series, this video is what you need. You need to watch this and learn some of the key pharmacological, fluid, electrolyte, IV therapy questions you may encounter. Let's get to it. The first one, critical thinking, right? Which lab results indicate that calcium gluconate is effective? It's effective. That is the buzzword. I don't want you to move until you understand what is effective. That means the medication is doing its job. And nurse is caring for a client with what? Hyperkalemia. Don't jump the gun, because I know if you jump the gun, you're going to pick a wrong answer. Patient as what? Hyperkalemia, receiving calcium gluconate. Which lab results indicate that what? The results, what? The medication is effective. Effectiveness, that means it has done its job. Stop the video, try to answer this question, and then play it back and you see how I'm going to approach it. This is the way I will approach it. I hope you already giving me your answer in the comment section, and I will take a look at it. But what is the question? Hyperkalemia, potassium is 5.9. And I'm receiving calcium gluconate. Then the content, the fundamental, the critical thinking skills associated with this particular NCLEX practice question pharmacology review regarding IV fluid therapy medication is what? If I'm giving you calcium gluconate for hyperkalemia, I'm not treating your hyperkalemia. What am I doing? I'm just trying to stabilize your heart. So it just stabilizes the cardiac dysfunction. And therefore, when you're picking the answer, even though potassium is low, that is not the function of calcium gluconate. This is how the critical thinking come in. This is the way I want you to apply these kind of questions. NCLEX will challenge you. And therefore, I'm challenging you with this question. Not number one, it's not the right answer. Don't pick it because it's normal. Normal EKG, what do you think? I've given you the clue. Your calcium is going to go up a little bit. It does not mean it's effective. Magnesium is irrelevant at this point. The effective medication, effective effect of that medication is what? Normal EKG. And this is the first question. This is how all of the question is going to be. And this is the way I want to approach answering question, critical thinking, NCLEX practice questions and answers. This is our pharmacology review, part 16. Calcium gluconate doesn't lower your potassium. That is the concept I want you to take with you when you see the question, but it's going to stabilize the cardiac memory and prevent what? Arrhythmia. Therefore, number 2 is the right answer. Question 1 down. Question 2, same strategy. Which finding indicates effectiveness? This video was designed to teach you test-taking strategy, critical thinking, and use the buzzword. You see how the questions are just 2 lines, similar to what you will see on the NCLEX. There is no ambiguity. All I'm saying is effectiveness. And let's evaluate a client receiving what? IV albumin for what? Hypoproteinuria. That means your protein is low, you have low albumin, and therefore I'm giving you albumin. What shows that the albumin has been effective? I underline the buzzword, the keyword I'm going to focus on, IV albumin and effectiveness. That's all. Crackles in the lung. Is it a problem? Increased urine protein. Is it a problem? Is it a JVD? Is it a problem? Decrease edema. Is it a problem? all of them, what do you think? Do they show effectiveness that albumin has worked? Then you go back and you ask yourself, why do I give you the albumin? Why do I give you? In all NCLEX questions, you ask yourself the definition of the problem, right? And then how does it apply, right? This is the problem. Albumin is used to pull fluid into the intravascular system. Therefore, if I give you albumin and this is your tissue, all this fluid come into the intravascular system. So what is it going to do? Your skin is going to dry because it's pulling fluid. If this is your abdomen, it's going to pull fluid into the intravascular system. What do you think? If I pull down fluid, the purpose of the albumin is to decrease edema. You see lung crackles, you think, oh, it's airway. Well, that is a side effect. If you put too much fluid into the intravascular system, you go to your lung and you have crackles in your lung, bad effect. If you see protein in your urine, that means the kidney is in trouble. You have leakage of protein, that's bad. If you have JVD, that's fluid overloaded, side effect. But if we have decreased edema, albumin has done its effectiveness. That is the job. And you can see how these questions are not that difficult, but it's designed to challenge you. If you do NCLEX question and this doesn't challenge you, please try and find some questions that will challenge you because you don't know what you're going to get. This is what it is. Reduce edema. Don't pick crackles in the lung or JVD. Those are bad problems, but they are designed to trap you. And then she's reviewing lab results for several clients. This is the same thing. Go back to the basics, the fundamentals of clinical medicine. Which electrolyte imbalance should the nurse recognize is most dangerous? So which electrolyte balance should the nurse recognize is the most dangerous? What do you think? Sodium of 125, potassium 6.5, magnesium 1.3, calcium 7.5. They are all abnormal lab. But if you're doing patient prioritization, NCLEX prioritization, which one do you think is the most dangerous one that are going to kill the patient right now? And this is what I call B-sharp, right? B-sharp, we have the E is electrolyte. And these are the electrolytes I talk about. Sodium, potassium, magnesium, calcium. Which electrolyte is going to kill you? Sodium, you're going to have seizures. Calcium, you're going to have seizures. Magnesium, the same thing. Thus, cardiac arrest. Who do you think is going to die first? You know the answer. I know you watch Adapting class, so you pick the right answer. Severe hyperkalemia is life-threatening due to the risk of cardiac arrest. I will pick number 2 as my right answer. And then she's caring for a client with what? Hyponatremia. This is also content-based. I want to show you something if you see it somewhere. Who is receiving what? 3% hypotonic saline. Patient has what? Low sodium, is receiving hypotonic saline to correct the problem. 6 hours later, the nurse checked the lab and the sodium is now normal, 135. What do you think? I would like everybody to answer this question if you're watching this video. Think about it. Your sodium was 120. We started 3% to correct your sodium. 6 hours, my sodium is 135. What would you do? Prioritization, NCLEX prioritization, nursing prioritization. Continue the infusion at the same rate. You want to continue giving the patient 3%. Notify the healthcare provider immediately. Slow down the infusion rate or monitor urine output. What do you think? In prioritization, that means if you don't do something, patient is going to die. What is the problem with this? If you know the answer, put it down. But the content I'm going to give you, if you're correcting hyponatremia, you should not bring the sodium normal within the same day. It can take a couple of days, 2 to 3 days to bring the sodium normal. If you do that, you have something we call CPM, central pointing melanosis, and locking syndrome. That is a bad problem. That is a bad problem. So based on the content I'm telling you, what do you think? Continue the infusion at the same rate? You should not do that. Notify the air care provider. Think about it. Slow down the infusion rate. Think about it. Monitor the urine output. Of course, the urine output is going to increase. So I don't care about it. That's not the priority function. I'll continue the infusion rate at the same. That's bad problem. Now you're left with two problems. Two of these problems. One said lower the infusion rate. The other one said what? Call the air care provider. This is a bad problem. Increasing the sodium like that is so bad that you should not be the only person who knows these results. If you keep these results, the patient is dead. Because of that, you have to notify the air care provider. If you get trapped and you pick number two, it's okay, but I want you to use this strategy next time. When you find something that you know is a bad problem that can kill the patient, load the boat. We call it loading the boat. That means you're telling everybody about the story. You should be a gossiper at this time. Sodium is now 135. Tell everybody under the sun, because if you are the only one who knows this and problem happen, you are in trouble. So call the doctor. Don't slow the infusion rate. So too rapid correction of sodium is dangerous. Central pointing melanosis. We should tell the doctor right away. And this is caring for a client with sodium, 122. I'm using the same background of what I've given you the answer here. Which intervention should the nurse prioritize? Well, sodium is too low. It's going to have seizures. Do you restrict fluid? Do you give them half normal? Do you give them hypotonic saline? Or do you administer loop diuretic? This is nursing school NCLEX pharmacology IV fluid therapy. You have to know the strategy of how to correct electrolyte. It's going to come on your NCLEX, on your nursing school. You have to be comfortable. Hyponatremia means sodium is low. You have different kind of fluid. You have hypotonic, hypertonic, isotonic fluid. When somebody's sodium is too low, that means their sodium concentration is less than 1%. If it's less than 1%, you should give them something that is greater than 1%. Therefore, half normal is not good. You should give them something higher. 3% is good. Or you can give them 2%, but there's no 2%. What we use is 3%, 5%. So give them something higher. You can restrict fluid so that they don't dilute their sodium. So this is good, right? You can give them hypotonic saline that is going to correct the sodium, like we saw in question 5. You can also give them loop diuretic that will get rid of the fluid. But there's a content here. If you need help with fluid electrolyte, check the adaptant class. I have a bunch of fluid. This is a content. We restrict patient fluid if they have hyponatremia, if it's a dilution. They're drinking to dilute it. So dilutional hyponatremia. And we also give them loop diuretic if they have what? Hypervolemic, too much fluid, like ascites, and then you have hyponatremia. But in any case, if the sodium is that low, giving them fluid, restricting them fluid or furosemide is not going to help that much. You need to correct it. Otherwise, they go into seizures. So the first priority, question said prioritize. I will prioritize hypertonic to correct the sodium rather than restricting their fluid or loop diuretic. 1 and 4 will take forever. 3 is much better. You can correct it within 3-4 days. So this is the content that I spent some time there to understand this electrolyte imbalance and correction. So sodium is too low. 3% is your priority. What is your score right now? Number 6 can be challenging. It's okay. If you don't get it, we learn it together with adaptant class using IV fluid, electrolyte, IV therapy, NCLEX practice question, pharmacology, practice test, review. What is the question? For which client is the medication indicated? I mean, we got to give it to them. you have to know the indication of this medication. What is the medication? And nurse is caring for several clients who have what? New prescription for what? Calcium gluconate. Who will you give calcium gluconate to? I know you've seen this multiple times. You've read it somewhere, you watch videos. Now, I put it in the question form. Who do you give calcium gluconate to? Pharmacology. Is it somebody with potassium 5.9 and EKG changes? We saw it, right? Somebody whose calcium is already low. Somebody whose magnesium is 7.5. Somebody whose sodium is 125. Somebody who has Toxicity depontes. Like I said, critical thinking, trying to challenge you. But I know you watch adapting, please, and therefore you can handle this. Select or apply. I want you to master it. Don't pick everything. Those that you know you pick 110%, 150%, 200%. There's no 200%. What I mean is what? You have to be completely 100%. If you are 99.9, leave it alone. Yes, we give a patient who has hyperkalemia with EKG changes, we give them what? Calcium gluconate. 2, if your calcium is low, we're going to give you calcium gluconate. We can use it for magnesium, but this magnesium is high, but there's no symptoms. We use it for magnesium toxicity. If you show signs of toxicity, here I don't see just a normal. So we can slow down the infusion rate. But if you have symptoms, we give you calcium gluconate. It's unrelated to sodium. And to solve the pointage, you don't use calcium, you use magnesium. So that is the content. This is the hardest of all the questions that we have. But this is what you have. Calcium is used for hyperkalemia with EKG changes, low calcium, and magnesium toxicity with symptoms. And therefore, 1 and 2 are your right answer. Which client should the nurse question before starting lactate ringer? Have you seen this question before? Have you read about it? I know you know it, but in the question form, this is the way testing your knowledge, critical thinking, put everything together. The key word is what? Lactate ringer. Lactate ringer. What do you think it is? Lactate ringer. Nurse is going to question prescription to that. Even if you don't know what to do, look at it. Patient has GI bleed. He's bleeding. Does he need lactate ringer? Patient has hypovolemic shock. Does he need lactate ringer? Patient has liver disease. Does he need lactate ringer? And patient is after surgery, post-surgery. Can you give them lactate ringer? The concept here, write it down. Concept. Lactate is usually broken down in the liver. You get the content now. So I know you pick the right answer now. What do you think is the right answer? If I can only work until broken down by the liver, well, if I have GI bleed, it's fine. We can use it. If you have hypovolemic shock, we can use it. But if you have liver disease, you cannot break this down. After surgery, you can use it. Therefore, 3 is the right answer. So don't forget, anybody with liver disease, lactate is not good for them. So LR, you cannot use it. LR contains lactate metabolized by the liver, contraindicated in the liver failure. Number 3 is the right answer. And this is the biggest of all. Dose calculation, magnesium sulfate. If you're in nursing school, you're struggling with this, this is for you. If you're preparing for your NCLEX-2, I'll give you the strategy. You can use it. But they will give you these long questions. Magnesium questions is long because they will give you a loading dose and a maintenance dose. I'm going to make it easy, straightforward. Use this strategy to answer these kind of questions. Don't let them trap you. So take your time. It's long, but don't worry about it because that's the way magnesium questions are. A client with preeclampsia, that means he needs magnesium. That's all. And he's prescribed magnesium sulfate. I said that, right? With the loading dose. So this is the key. Loading dose. You got to load the individual with what? 4 grams, a large amount of magnesium, 4 grams over 50 minutes. You just bolus them. Then after that, you got to give them maintenance dose of what? 1 gram every hour. Then he said, if the IV solution contained what? 2 grams, that's your key. They're telling you the concentration is what? 2 grams magnesium sulfate in what? 100 ml. At what ml per hour should the nurse set the infusion pump for the maintenance dose to be what? 1 gram per hour. A bunch of information. Look, the way to answer this kind of question, once again, if you're in nursing school, you're struggling, don't worry, I got you. The way to answer the question is to answer what it's asking you. It said at what ml per hour, right? Therefore, you need ml per hour. Should the nurse set the infusion pump for the maintenance dose? We're dealing with maintenance dose. Therefore, this loading dose information is irrelevant. Forget about the first portion. You're done. Don't even look at it anymore. The 4 gram over 15, that is a what? Loading dose. We're supposed to deal with what? Maintenance dose. So MD dose, right? Then you ask yourself, what is the concentration of the medication? It said what? 2 gram in what? We have 2 gram in what? 100 ml of what? Solution. That's all. This is the same thing. If you divide it, you get what? 1 gram over what? 50 ml. That's all. 1 gram, every 1 gram of magnesium is within what? 50 ml. Therefore, if I'm going to infuse ml per hour, just use your dose calculation. That's all. Use your dose calculation. Straightforward. I'm going to change this into 50 ml per 1 gram because I just flip it. I want ml to go up. And then I just bring what? They say 1 gram per hour. That's the maintenance dose. Maintenance dose is what? 1 gram per hour. You cancel this and that, and you have what? 50 ml per hour. That's all. Once again, forget about the loading dose. If they ask you the loading dose, it's the same thing. You do 2 gram over 100 ml, and you convert the 4 gram, which is will be like 4 times that will be 200, right? If 2 grams is 100, 4 gram will be 200. That's all. And then you use the same thing. So for this one, 2 gram over 100 is the same as 1 gram over 50, right? Which is what? 50 ml over 1 gram. And then you multiply 1 gram per hour, you get 50 ml per hour. So that's your right answer. This is dose calculation regarding magnesium. If there is a maintenance dose, calculate the maintenance dose. If there's a loading dose, calculate it. Like I said, for these magnesium thing, they will give you too much information. You don't need to use them. If they say loading dose, focus on loading dose. Maintenance dose, focus on maintenance dose. Which action is correct? And then it's prepared to administer what? 10 milliequivalent IV potassium chloride to a client with what? Hypokalemia via peripheral line. This you have to know. It's a good thing to know for your nursing skills, for your fundamentals, when you're taking care of the patient, in addition to nursing exams prep, right? What is the problem? Magnesium, potassium, there's a way you give it. Do you use infusion pump, IV push? Do you mix with antibiotic or give it over 30 minutes? Straightforward content. What is that? You know it. Never dilute it, number 1. So don't mix it with anything. Use a pump so that you can control the rate. Don't push it. No IV push. And you can give 10 milliequivalent every hour. Therefore, infuse over what? 30 minutes too fast. That's the problem. You shouldn't mess with antibiotic. Pushing is deadly. We should give it as IP pump. Content, English strategy, test taking strategy. We've seen this already. A nurse is caring for a client with hypovolemic shock. What I mean in the concept, patient is in shock. Which IV fluid order should the nurse anticipate? The content here is, if you're in shock, any shock patient, they need isotonic fluid. Therefore, which fluid is isotonic? This is hypertonic solution. This is hypertonic. This is hypotonic. This is isotonic solution. That's what we're going to give it to the patient. Either lactate ringer or 0.9% of normal saline. So isotonic fluid, it's 0.9% normal saline or LR. They are using shock. And this is caring for a client with what elevated ICP who is receiving mannitol, which finding indicate that the therapy is effective. Once again, test-taking strategy, effectiveness of the therapy. Patient has elevated ICP, is getting mannitol. That means neurological problem. We want to lower the ICP. That's why we give the patient mannitol. What is mannitol going to do? Pull fluid from the brain, take away the edema. The effectiveness of this is improve ICP on neurological problem. What do you think is the best answer? This is a test-taking strategy. I know a lot of people will pick what? Krakows head in the lung, but that is still not the right answer. This is the same question we saw as number one. I give you mannitol, I pull fluid from your brain. What I'm doing is what? I'm trying to improve your ICP, and therefore, Krakows head in the lung is what? Not effectiveness, is what? Side effect. GCS, Glasgow Coma Score, that is improved from 8 to 10, is a good thing. That is effectiveness of the medication. Urine output is going to increase. It's an expected finding. Glucose may go up, but that is not what? The effectiveness of the medication. Krakows head in the lung base is a side effect. Don't pick it. Pick number two, that your GCS is improving. It shows the effectiveness of that medication. So number two is the right answer. This is a test-taking strategy helping you master this IV therapy medication. And as care for a client receiving Furosemide, which concurrent prescription will require clarification. Concurrent medication. What it means is a fancy word. Means you combine it with furosemide. If we need clarification, that means it's a bad problem. What is furosemide going to do? Hypokalemia is what? Loop diuretic causes hypokalemia. Watch the cardiac medication series that I did. It's the first video that we did. You should watch it. It's very important. You know all the cardiac medication. It causes hypokalemia. And therefore, if I give you potassium with furosemide, that's a good thing, right? Digoxin had low potassium. Do you think is a good thing? Sodium restriction. That is the reason why we're giving you furosemide. Furosemide is going to get rid of your sodium. So we want you to have a restricted diet in your sodium. Checking your weight is good. But taking it with what? Digoxin is bad. It causes hypokalemia, and we're going to have digoxin toxicity. So loop diuretic causes hypokalemia, increasing the risk of digoxin toxicity. And I should clarify that order. This may be challenging to you, but this is why we're doing this. Know this. Phenytoin, setting strategy about medication administration is a safe medication administration. A nurse is preparing to administer IV therapy to a client with what? Seizure. Which action is a priority when administering IV phenytoin? What is the safe administration strategy for Phenytoin infusion? Infuses more than what? Infuse not more than what? 50 milligram per minute. Flush with what? Dextrose solution, the IV. Infused with what? 20% of what? Albumin. And then mix it with other drugs. If you know it, I'm happy for you. If you don't, we are learning. But I want you to try. Use the strategy I've told you. Phenytoin. There's a reason why all those information there is to test you, challenge you, critical thinking. If you see the ankles and you have no clue about this, don't run away from it. Try to answer it. Look at the answers. One said mix it with other drugs, and then another one said infuse it with 25 5% albumin. That should tell you 2 answers saying mix it with something. It's the same thing. The third one also says flush it with dextrose. It's the same thing. That means the content is phenytoin must be infused with sodium chloride, normal saline. That's what you need because it causes hypotension and arrhythmia. You should not go faster than 50 milligrams. Second, you should not mix it with dextrose. It will not work. Albumin, it hates protein. You should avoid it. Therefore, you should avoid it with any other medication. 1 is the right answer. 14, 2 more left. A client receiving IV dopamine reports pain at the IV site. Dopamine is a vesicant. If you have pain, you have necrosis. Therefore, we have extravasation of a vesicant. What is the therapy for the management? What is your priority? Slow down the infusion, prepare for phentolamine, apply cold compression, and then reassure the client. I've given you the content here. What do you think? What do you think? What would you do? Slow down the infusion, prepare to give phentolamine, apply cold compression, and reassure the client. Bad problem. Vesicant is a bad problem. We may have necrosis of the skin. Slowing down the infusion is not good. The first thing you should do, stop the medication, call the doctor, and then have a prescription ready for antidote. The antidote is phentolamine. Cold compression will prevent blood flow. You should allow blood flow. Therefore, we should use warm compression. Reassuring the client is a bad problem because this incident, you got to file incident report. Therefore, this is what we need to do. Number 2. Any last question? A client receiving magnesium sulfate for preeclampsia developed what? Respiratory rate of 8. We saw a similar question. I'm trying to let you think critically. A patient getting magnesium and the respiratory rate of 8. That means he has symptoms now. He's having toxicity associated with the medication. If you have toxicity, you got to do something. Decrease the infusion rate. You think it's a good thing? Calcium gluconate. Document the finding, recheck. If you have toxicity, do something to take care of the toxicity. Give the patient antidote. This is the best choice. Therefore, the right answer is what? Administer calcium gluconate. Decreasing the infusion rate is not going to help. You need to stop it and call the doctor, have antidote ready. Documenting the finding is not good. Rechecking 30 minutes is not. 15th question, English practice question. Pharmacology practice test. Number 16, IV therapy, medication, safe medication administration, and electrolyte. Thank you for watching. And if you like this video, put a comment, share it with your friends, and follow the series. Or join Adapting Class, subscribe for more content like that. And take care of yourself. Good luck.